So as I press play, you're drawing a line from the base of the nose, the ALA, to the part of the ear. Let me turn the volume down there. What are you doing? Well, what's the point of that line?
So these lines, they're called Frankfurt planes, and they have a couple of roles. So firstly, they're to make sure that we are symmetrical, so that we're putting our injection points in a symmetrical way on the face. And the other role is that they keep us safe as well. So if you might be able to notice that these two lines, they make up 4 quadrants.
Yeah.
So they keep us safe from different arteries and veins on the face. So you'll notice in the sort of lower quadrant here, we've got the facial artery. In the sort of more medial quadrant, we've got the infraorbital artery.
Yeah.
And then this area you see on the cheek, generally we know it's a very avascular area. So it's quite a safe area where we can inject
avascular,
cheek
for those
filler.
who don't know, means less blood vessels. Yeah.
Exactly, yeah. So once I've drawn out the Frankfurt planes, I've got a sort of rough guide of where I want the cheek injections to go. And then now you just see me drawing out, I'm drawing out the orbital rim. So this is basically telling me if I go above that point.
Yeah, the rim of the eye
exactly,
socket.
Yeah. So I don't want to go right into the eyeball.
Yeah.
So it just keeps me safe from that as well. So here I am. Now I'm basically revolumizing the cheek.
Yeah.
And I think treating the anterior cheek, well, for those who don't know, anterior means front.
Yeah.
So I'm treating the anterior cheek usually in combination with the tear trough.
Yeah.
Because it just gives a much more kind of overall, more complete result.
Yeah.
So this is what I'm doing here.
So your needle there right now, and what we just saw, that was on the bone.
Yes.
And that was kind of trying to address both the cheek and the eye at the same time.
Exactly. Yeah.
And what we've got there now on screen, people are going to go, that's an absolutely enormous needle. But it's not a needle, is it?
Exactly, yeah. So it's called a cosmetic cannula.
Yeah.
So what it is it's a blunt tube that doesn't cut through any tissue. So it's not sharp like a needle. It just kind of wiggles around in that superficial fat compartment. And there's a couple of benefits. So 1, there's much less swelling. 2, it's much safer as well because we're not able to perforate vessels. And 3, we can easily sort of place that filler in a very even way.
Okay.
Into that tear trough.
like a knife spreading butter on a piece of toast almost.
Exactly, yeah.
Yeah. So what filler are you actually using in this particular instance? I can see it's got a slight blue plunger on it.
Probably guessed already. Yeah. So it's Teoxane Redensity 2.
Okay.
So this is the one I use pretty much all the time for tear troughs.
Okay.
The reason why, it's the least hydrophilic filler on the market.
Okay.
And it's particularly important here because the tear trough is very thin skin.
Okay.
We don't want a very hydrophilic filler which draws in water and at least puffiness.
Exactly.
And because I'm also putting fillers superficially under the skin,
Yeah.
it makes it extra important as well because anything that's close to the skin and it's hydrophilic, it will start to become puffy.
Fine. I mean, personally, when I do tear trough, I like to almost underfill on purpose.
Yeah.
So instead of making it look great on the day, I want it to look like it could still be volumized a little bit more.
Yeah.
I want to filter probably, let's say, 75, 80%. And then over time, it will probably reach 100% by itself as well. Are you quite similar in that aspect?
Fairly similar, yeah. I tend to push it a little bit more, probably like 90, 95%.
Yeah.
What I find really helps is that when we treat the cheek as well, because we're treating deep, so periosteal, underneath muscle, below the SMAS, we can achieve a lot of projection in that area. And it minimizes how much we need to actually place in the tear trough.
Yeah.
And then, it minimizes the risk of that puffiness as well.
Sure.
But yeah, I totally agree.
So periosteal, for those that know, is another way of saying on the bone. It's in layman's terms. And the SMAS is a connective tissue layer in the face. And depending on whether your filler is placed above the SMAS or below the SMAS, you're going to get a particular type of projection or lack of projection in certain areas. So now I can see you've got the patient sat up.
Yeah.
Whereas before they were lying down. What's the thinking behind that?
Yeah, so pretty much whenever I'm pretty much always sitting patients up just to kind of see what's the result at that point. Because you can try this on yourself at home. If you just lie back and look at a mirror, it's like you've had a facelift.
Yeah.
So patients, when they come into my clinic, they're literally up, down, constantly
Yeah.
throughout the treatment.
Yeah.
Because I'm lying them back to make them comfortable, do the treatment, and then getting them back up again and seeing how does all the tissue kind of drop down, how does the skin drape over the face,
Yeah.
and then we can correct from there.
Fine.
And then we got a better idea of what it's going to look like in real
Yeah.
life,
Same.
pretty much.
I mean, I'm especially when I'm marking up, I'll always try and mark up sitting up as well.
Exactly. Yes. Yeah.
And obviously the video's on a loop here, but when you were doing the cheek, I noticed you had a slightly different filler.
Yeah.
Which one are you using there?
So that one's a hard filler.
Okay.
So specifically, I use Intraline M4.
Okay.
And I use this because we want a filler that's got a good viscoelasticity.
Yeah.
So something that can resist force and keep its shape. Completely different from the one in the tear trough. We want something that's soft, that's not going to be visible when it's just under the skin. So using this very dense filler is going to be able to restore cheek volume and keep its shape, because it's underneath quite a lot of layers of the face as well. So we need something that's hard and it's going to maintain that shape without, despite the patient being, smiling, moving.
Fine. So Aaron and I use different fillers. You're going to see different perspectives. Those of you who have watched, not many of you, who have watched my 5-hour monologue on dermal fillers, which is extremely detailed, you know that the filler I always recommend is Revanesse. But Aaron's already mentioned 2 others, and they're perfectly fine. I would say the person holding the syringe is far more important than what's inside the syringe.
Yeah, for sure.
Yeah, I think most people would agree. So in this particular case, what else did you see on the face, if anything, that needed any kind of work? And we'll look at the before and after in a second.
I think in this case, it was just tear trough filler.
Just that on its own?
Was it just tear trough filler? Yeah, I think it was just tear trough filler this time.
Okay. We've got Aaron's manager basically sat over here, making sure he doesn't say anything stupid.
But actually, I think it's an important point as well, because sometimes knowing when not to treat is also as important as when to treat.
Completely
Because
agree.
sometimes, I say a lot of the time, doing less is actually more.
Yeah.
And I think there's a lot of people, they go to clinics and they're just sort of, they get so many different ideas and treatments kind of like pushed onto them. And, there's a lot of kind of financial motive as well. But I think a lot of the time, you want to just kind of take it easy. And, if something looks good already, just leave it alone.
Yeah, I agree. So when someone comes to you for a tear trough problem, like in this particular case, in this case, we can see that you've treated the anterior cheek or the front cheek, let's say about here.
Yeah.
And then you've gone into the actual tear trough itself. What's your decision-making process for those watching who are sat there thinking, well, do I need both, like this video, or do I need just a tear trough itself? What makes you decide that?
Yeah, so I mean, there's a couple of things. So first, it's classifying what type of tear trough do you have.
Okay.
So is it a true tear trough? So with a true tear trough, this means that you've just got a hollowness in the tear trough. And it's quite a simple fix. In this case, we're just treating the tear trough directly with a soft filler.
Yeah.
On the other hand, if you've got something called a false tear trough, this in simple terms means that you've lost volume in your anterior cheek, so the front of your cheek, and on top of that, you've got some fat herniation or protrusion from your infraorbital fat compartment, so the under eye fat compartment.
Yeah, so the fat about here, you're saying that's slipped forward because there's support underneath to slip down.
Exactly, yeah. And they will look completely different as well.
Yeah.
With a false tear trough, it's going to look more like a bag under your eye. So with that second false tear trough type, you have to treat the cheek with the tear trough. Okay. If you just treat the tear trough alone, you can actually end up making the tear trough look worse.
Yeah, because it looks overfilled compared to the hollow that's now underneath.
Exactly, yeah.
And I find also when there is a false tear trough, there is also quite a bit of a line here or a big depth here because the fat here has slipped down and folded over, and now you've got a big depth here as well as a bag here. And I think they're very commonly seen together. Do you find that in your practice as well?
For sure, yeah. And, adding to that, looking at the way that the face ages as well, typically most of the fat pads of our face, they tend to get smaller and
Yeah.
they descend with gravity.
Yeah.
Annoyingly, that fat pad you're talking about, the nasolabial fat pad, is the only one that tends to grow on the face as you
Yeah.
age.
Yeah.
So you end up getting really heavy here,
Yeah.
which accentuates lines down here as well.
Downward. Yeah.
Exactly. So you just end up with loads of shadows.
Now I'm going to pause the video here so we can see those cross lines that you've drawn from Hinder in 1975, if anyone's interested. Now, relative to where they cross, where are you aiming to put your needle?
Yeah. So one of them is exactly where all those lines are crossing,
Okay.
and that line is very predictable. You always see the sort of the deepest point of the cheek volume loss right in that point. So it's where the nose crosses with the tragus, 1 centimeter from orbital rim down to mouth corner, and then a line from the tear trough. It always seems to be there. The next one is just from your mid-pupillary line,
Yeah.
and 1 centimeter above that horizontal line. So those are, in most cases, where I'm putting all of the cheek injections when you need to revolumize the
When you want to
anterior
get the
cheek.
projection from the cheek.
Exactly, yeah.
Fine. So once you've drawn these, what are you trying to draw on the face next? Because I know you're going to draw in the video, if we let it play, there's a few other things you're drawing afterwards.
What I generally draw next is, so marking out the orbital rim.
Okay, so the edge of the eye socket.
Exactly, yeah. So making sure I'm not actually going to get into anywhere dangerous. I also do draw out where the infraorbital artery is as well.
Yeah.
Because
And where is that?
generally I find it's always in the medial pupil.
Okay, so in line with the middle of the eye.
Yep.
Yeah.
Or your canine. So
Okay.
your canine and
Fang tooth.
exactly, yeah. So that pretty much, always is where the infraorbital artery is.
Yeah. And we can see you drawing there the white line, and I think you're
That's
drawing
it.
the edge of the eye socket
Exactly.
specifically there.
Exactly.
So it's a visual reminder that do not put the needle higher than this line.
Yeah.
Simple as that.
Yeah.
You're drawing out
or
safety
more medial
margins.
than this line.
Yeah. So you're going to draw that horizontal line on the edge of the eye socket and then a line vertically in the middle of the eye.
Yeah.
You don't want to go inside that line
Yeah.
and you don't want to go above that line.
Exactly.
And that's where you're saying is safe.
That's it. That's it.
Completely. No, I do things a little bit differently. What I tend to do, instead of drawing a mid-pupil line, I just use my ultrasound.
Okay, right. Well, that's gold standard. there.
Exactly.
Yeah.
So I will take my ultrasound, I'll find the actual infraorbital artery, do a little dot instead of a line in the middle of the eye, and I can go anywhere that dot isn't. That's
Right.
the way I prefer to do it. But both are valid. And there's nothing wrong with that. And I think patients will say, sorry, go on.
Yeah, no, I mean that's the next step for me, sort of, getting the ultrasound in and just sort of relying more on ultrasound guided injections.
Yeah. I think that's where things are going to go in the industry. And it's already started.
For sure.
A lot more people are doing it. I know a lot of people are reluctant to invest the money in it. But I think it's worth it for the knowledge and the relaxed evening that you have after clinic.
Exactly, yeah.
Patients won't know this, but whenever anyone places filler, like you or I or anyone else, there's always a little voice in our head. What if we didn't put it in the right place?
Exactly.
Because, why don't we talk about the risks? The risks of the dermal filler. I think everyone's seen horror stories. The worst case scenario is it's placed inside a blood vessel. That vessel is then blocked. Everything downstream no longer receives blood and therefore oxygen, etc. And I think the worst horror stories that people have seen and heard are because of this, right? This vascular occlusion.
Yeah.
And what kind of things do you as an injector do to minimize the risk of that happening?
Yeah. I mean, it's a valid concern, and I have had vascular occlusions before.
Yeah.
Luckily, all of them have been picked up like within seconds. And reversed. And the patient has come back with no sort of complications and being able to have the treatment. But yeah, so the things I would do to kind of minimize the risk. So first of all is, of course, injecting only in safe areas. So that's why we draw these markings to make sure we're away from arteries and veins. The other thing is we also inject in very small boluses at a time. Because
what's a bolus?
So a bolus is just when we're finding a point, injecting like a ball of filler into an area.
It's a technical term for ball, really, isn't it?
Exactly, yeah. So a little micro ball of filler. And so the benefit is that, let's say we actually are in a vessel. it's much better to cause a tiny occlusion with a micro bolus of filler rather than a big bolus of filler, and that's going to completely occlude that artery or vein.
Yeah, block it.
So, that's another reason. So we do small bolus of filler.
Yeah.
And in some areas of the face, I also do aspirate as well.
Yeah.
So typically with the bridge of the nose, that's what I would say is probably one of the highest risk areas on the whole face.
Yeah.
I'll typically find the bone, and then whilst I'm staying very, very still, I'll aspirate on the syringe, so pull back on the plunger.
Yeah.
And then that negative pressure should aspirate blood if we are in a vessel.
So aspirate means pulling, instead of injecting something into a location, pulling what's in the location into the syringe. So if you put a syringe into a mug of red liquid and you pull back on the plunger, when you pull back on that plunger, you should see red liquid start to fill up the syringe. So it's done in blood vessels to check, am I in a blood vessel? And that's essentially what you're saying, isn't it?
Exactly, yeah.
And I think that's all you can do to try and prevent occlusions. And I would also say, and you tell me whether you would agree, if a clinician causes a vascular occlusion, i.e. a blood vessel blockage, they could have taken all the safety precautions and done everything perfectly, and that still happened, right?
Exactly.
It's a bit like you're doing all the research on a company before you buy shares in that. Suddenly, unexpectedly, the CEO runs off with his secretary, the shares plunge. You didn't do anything wrong because you couldn't have predicted that.
Exactly.
And it is a lottery. And I think you're right. I think drawing safety markings, being prepared to reverse and all these sorts of things, I think that's all you can do, and having a great understanding of anatomy, right?
Exactly, yeah. You stay away from all the major arteries and veins, but the truth is, the face is a massive web
It's
of
a minefield.
vessels. That's it, yeah. So no matter what you do, you can still cause an occlusion.
Yeah.
But a safe practitioner will know how to manage an occlusion when it does occur.
And I think it's not about whether you get an occlusion or not. It's about, are you prepared for it when it happens?
That's it.
Like, for example, you've had vascular occlusions. I know you have, but it's never been an issue.
Yeah, exactly.
Because you've just recognized it and gone, okay, fine.
I've actually got one documented on Instagram as well. So I've actually filmed the whole thing.
Yeah,
so.
well, that's fantastic. I mean, a lot of people try to pretend they've never had one.
Yeah.
But it's great to see you do that, because it shows that if a patient wants to see you and they get it, they've got nothing to worry about. They just give you a message, hey, look, I think something's blocked. Can I come in?
Yeah.
Job done.
That's it.
A blood vessel blockage, I believe, is not a problem per se. It's a problem if you're left on your own and it's left to progress. If you notice a blood vessel blockage, what you need to have in place prior to treatment is an agreement with the person providing the treatment. What do I do if I suspect this has happened? And then if it does, you just carry out what you agreed, and then you're fine. As long as you're calm, you'll be fine. As long as you go to someone that can do it, isn't it right?
That's right, yeah.
And I think a lot of people don't realize, in order to dissolve it, you need the actual dissolving agent.
Yeah.
And you can only get that dissolving agent if you have a medical license like us to actually prescribe drugs.
Yeah, exactly.
And that's why if you go to someone not medically qualified, legally, they can't get a hold of that dissolver. And so I think it's not necessarily there's greater risk, there's a greater inability to dissolve a vascular occlusion, at least in the UK, if you go to someone who is not medically qualified and therefore can't get that dissolver. So I think that's pretty much everything on this case. Why don't we take a look at the before and after and then see how it turned out. Let me just close that for a second. Was it this one?
That's 10? The one, yeah.
Number 10. There we go.
Yeah. So you can see an improvement in the hollowness under the eyes.
Yeah.
Obviously, there's one thing that can't be really improved with dermal fillers, which is hyperpigmentation.
Yeah.
So you can do other treatments to further improve the eyes as well.
Yeah.
So you can try Sunakos, which is like a injectable skin booster.
I think everyone on this channel knows enough.
Oh yeah, of course. And then there's also if you don't want to have any more injectables, you can also try topical treatments as well.
Sure.
So there's like hydroquinone, extremely effective.
Yeah.
And also starting to introduce retinoids into your skincare as well can really improve that hyperpigmentation.
So has this patient actually had any previous work done?
I don't think so.
Okay.
I don't think so.
Fine.
Yeah, pretty much.
So in terms of that under eye area, if the patient said to you, look, it's less hollow now, I think that's pretty obvious, but I want the texture of the skin to change. Is that something you refer for? Is that something you have a chat about at all?
Well, I mean, then it's more a chat about topical treatments.
Yeah.
So, if she wanted to improve skin texture, I would definitely start her on maybe retinol.
Yeah.
Like a retinol 0.1%.
Any particular brands that you personally go to for your patients?
Personally, I use Abaji.
Okay.
I think they're very, they're reputable.
Yeah.
They always sort of work very well for my patients.
Okay, cool.
Yeah. What about you?
I mean, for that, looking at that personally, I would have done things a little bit differently, actually, in this case. So I would have said to the patient, what bothers you first? I'm sure you did. And that if the patient mentioned the texture, my personal preference actually would have been to treat the texture first.
Okay, right.
Because if I was to use something like a laser to do that, it's very difficult to do a laser after filler.
Right.
Because of the heat and the damage it causes that might affect the filler.
Right.
So my personal preference would have been skincare as well to prepare the skin, and then do something like energy device to really resurface the skin.
Yeah.
With or without Synagos before and after, if the budget is there. Once we've got the skin great, my personal belief and my clinical experience would be just doing that alone actually minimizes the look of volume loss. So on the left-hand side, we can see that hollow and that actual dip down. My view is when we see those on patients, those dips, that's not just because the volume underneath is gone. It's a combination of both volume that's gone and whatever loss of skin quality. Because if the volume's gone a little bit, but the skin is really loose and lax, it might exacerbate the appearance of volume loss. So if I get rid of that skin laxity first, if I start to smooth that out completely, I generally find the appearance of volume loss is much less.
Yeah.
And I need a little bit less filler afterwards.
Yeah, no, that's definitely a good option as well, sort of improving the skin quality first and then the filler. Because also the filler kind of looks better as well when the skin quality is improved.
Yeah, and you need less, so there's less risk as well.
Exactly, yeah.
However, she's got a brilliant result. I think that's taken a few years off, and she looks like she's had great sleep as a result.
For sure.
But for patients who are doing the filler first, I think I would do what you said. So we would look at things like the skincare. I would probably add in something along the lines of LED treatment as well. Completely non-invasive, doesn't even touch the skin. It's not going to interfere with the filler. I think that's probably another option that
definitely. And also, if you're on a budget as well, definitely good incorporating the skincare and the filler. It's not going to cost you a huge amount of money.
Yeah, relative to something like this. Yeah. No, especially if you look at the cost of like a big laser.
Yeah.
You're talking 4 figures most of the time, aren't you?
Exactly.
So for something like this, what kind of price range, if you're happy to talk about that, what kind of price range would you look at for what we've seen on camera, i.e. the front cheek, the anterior cheek, the actual tear trough itself, the under eye hollow, and then maybe talk about what it would cost for someone to look at something like the retinol that you said as well.
Okay. So typically 2 mil tear trough treatments are 700.
Okay.
If it's just 1 mil, it's 450.
This is pounds, by the way, for the international viewers.
And I would say majority of people, they always do have some degree of anterior cheek volume loss as well.
Okay.
So I would say most of the time you're using 2 mils.
Okay.
Then with the topical treatments, you've got retinol. So you can pick up retinol for about £70.
Yeah. That particular one that you mentioned, the Abaji one.
Abaji one.
Is it a cream? Is it a serum?
It's a cream. Yeah, so you can use it morning. With retinol, you want to generally start off only 2 days a week.
Okay.
And then if your skin is tolerating it, you can increase the number of days using it.
Yeah.
And the other thing I
generally work the same way.
Yeah, and the other thing I mentioned was hydroquinone. So this is it's also a medical grade topical treatment. It mainly works on your melanocytes. So these are the skin cells that produce melanin. What it does is reduce their activity, and because these melanocytes won't be producing as much melanin, naturally the skin starts to lighten over time.
So if anyone's interested to look that up, hydroquinone is sometimes shortened to HQ if you're looking up scientific papers. And they're going to act on an enzyme called tyrosinase. And that is an enzyme that is used to produce the final product, melanin. So you're looking at, with everything thrown in, somewhere between, say, 700 and 900
Yeah, something like
for
that.
all the injectables we've seen, for those topical skincare products that you said as well.
Yeah.
And this was all done in one session.
Yeah.
And in order to do the topical skincare as well and the hydroquinone with that, what kind of time frame are you looking to try and see a noticeable improvement with that particular brand that you like to use for your patients?
So I would say hydroquinone, in my experience, actually works really quick.
Okay.
I've seen clients have really noticeable difference in hyperpigmentation after about 8 to 10 uses.
Okay.
So this is like within a couple of weeks for some clients. Others takes a little bit longer, maybe 2 months or so.
Okay.
And then with retinol, I would say also about roughly a month, you'll start to see very good difference.
Okay.
One thing about retinol is that it can make your skin peel quite a lot.
Yeah.
So, some people find it a bit difficult to get used to at the beginning.
Yeah.
But, there's always use it with a good moisturizer as well to sort of maintain the moisture of your skin. And it will make that sort of redness and that peeling more manageable.
Okay. It's interesting to hear that because I think the viewers of this channel are used to me saying very different things. It's nice to hear a different perspective and have that discussion. I mean, I personally, I don't tend to use retinol too much. What I tend to go for in terms of retinoids, which are vitamin A compounds, is more towards something like tretinoin.
Okay, yeah.
Because it's much more powerful.
Yeah.
But I think retinol, for someone who wants something much cheaper, much more affordable, and is willing to accept slightly less result in the same amount of time, is a decent alternative.
Yeah, no, to be honest, I'd agree. I even use tretinoin myself.
Yeah.
But it's just that I find there's a lot of clients who have very sensitive skin. That's why I'm not always keen to give them something that strong.
Okay.
Because they'll come back to me saying, oh my God, they'll be panicking because of how red they are, how sore they are.
Yeah.
But, if I can see that they're going to sort of be able to tolerate that quickly, fine, go for tretinoin. Yeah.
And then in terms of the moisturizer, again, I'm a very different-minded person, actually.
Yeah.
As I'm sure you probably know.
Yeah.
I pretty much never, ever recommend moisturizer to patients.
Right.
So I think it's nice of viewers to see how different people work.
I haven't actually watched that video yet, but what just remind me, why do you not recommend it?
The reason... the hyaluronic acid based. It's not that I necessarily say moisturizer bad. It's topical hyaluronic acid, and you find them in moisturizers. Now, the way hyaluronic acid is hydrating is the same way that, for example, lactic acid is hydrating. To be technical for a second, but I will translate. Essentially, what's happening is there is a certain element of, no pun intended, electronegativity that oxygen possesses, and this electronegativity forces the movement of the electrons between that and the hydrogen onto itself to ionize that, create a polyelectrolyte in the hyaluronic acid chain, which then attracts cations such as sodium and potassium, and then you get hydration spheres or solvation spheres or shells built up around them. And that's the source of the hydration. But the problem with hyaluronic acid is it's in the dermis, right? It's in the second layer of the skin, not the first layer, which is the epidermis. And when you look at natural hyaluronic acid in us under a microscope, let's say, in the dermis, it's a particular type in terms of molecular weight. That molecular weight cannot be rubbed on top and delved down. If it could, that means we have no skin barrier function and probably be dead, because then toxins could probably get in as well. And that's why I never do it. Instead, I get nutrients to the cells because they produce their own hyaluronic acid, which is far better than anything we can rub in because they've had 4.5 million years of practice, not a $50 million budget on a massive company. And so for that reason, I personally never recommend the HA products, and yet my patients never have dry skin.
Okay.
Now, I think there is a place for HA for people who want to reduce symptoms. For example, what you just said. If they mix their tretinoin and moisturizer, it might feel a little bit better on the skin, might reduce the symptoms temporarily. I get that, and there's a place for that. But is it actually having a physiological benefit? I think that's a different conversation.
Right. I see what you mean. So you suggest more sort of healing the skin from the inside out,
Exactly.
rather than applying sort of like a bandage.
Yeah,
to,
instead of applying end products,
yeah,
which our cells make themselves anyway,
right.
we put in starting products so they can make the end products instead.
Yeah.
And I also, if they do want a little bit of relief from tretinoin, one of the things I also like to use is squalane oil
Okay.
instead of moisturizer, because there's no hyaluronic acid in that. And if your hyaluronic acid doesn't penetrate into the skin, it sits higher, it's still, the chemistry is still the same, because there's still electronegative oxygen, which attracts a cation and then creates hydration, pulls in hydration. But because it's not penetrated, it still has to pull in the water from somewhere. So it could pull it from your skin,
Okay.
out of the dermis.
Squalene. I'll have to look into that one.
And that's why the day you forget to put moisturizer on, sometimes your skin feels dry.
Okay.
If your moisturizer was hydrating you all this time, why would it have left you dry?
Okay.
What I find is when I get people to drink water plus electrolytes, hint, hint, not pure water, and then they use an oil like squalane oil, not permanently, but at least to reduce symptoms, they're getting the hydration inside and the oil is on top, so that water and oil don't mix, right? It's a polar and non-polar substance. They can't mix together. So the water doesn't evaporate out as easily, so it's trapped in.
Right.
So they retain the hydration.
Okay.
And that's where I prefer to do it. But maybe give it a try. Let me know what you think.
I'll
Mixing
look
it with the
into
squalane
these.
oil.
Yeah.
And the one I generally recommend is from The Ordinary. I think it's probably less than £10. And when I say that, they trust me very much straight away, because they know I'm not selling anything and I just recommend something.
Right.
But then they can still get the tretinoin from me, because you can't buy that commercially. It has to be prescribed.
Right.
So yeah, let me know how that goes. Yeah. Did you prescribe any skincare for her in this case?
No, not this time.
Okay.
But
fine.
I gave her advice on what to use.
Okay.